Alright, so today we're going to review renal disorders. We're going to start with general infections, then we'll transition to various disorders that could trigger renal failure, and then we'll conclude by examining the key neoplasms that we see in the renal system. Now, infections within the urinary tract or the renal system can affect several levels. It could affect the bladder, the ureters. We call that cystitis. Itis indicates that there is an inflammation, usually triggered by an infection. Or it could be in form of pyelonephritis, and pyelo is in reference to the kidney, so this time the infection either affects the renal pelvis or the substance, the parenchyma of the kidney itself. In terms of where that infection comes from, well, there are several infections. The infections or the organism can spread through the blood, hematogenous spread, or it could be an ascending form of infection. Usually this is the case when, for example, there is a urinary tract infection or a bacteria that is introduced through a scope, through an examination of some sort, a tool that has been used, and so on. Now, with cystitis, the term cystitis refers to infection and subsequent inflammation that affects the urinary bladder and the ureters. Patients with cystitis complain of sense of urgency. They may develop pain. There's increased frequency of urination, and sometimes, especially in advanced cases where there is damage to the cells, there may see bleeding in the urine. We call that hematuria. You can see the inflammation here. The inside of the bladder has kind of hyper or dark pigmented areas that indicate there is some sort of inflammation. So there is the hyperemia, and that basically occupies the mucosa within the epithelium of that bladder. The next example is pyelonephritis, and this time the infection is kind of diffuse within the renal pelvis and the parenchyma of the kidney. The most common cause is a bacteria called E. coli, which is a normal inhabitant of the gut, and this could affect both genders, although it is seen commonly. Overall, urinary tract infections are more common in females simply because females have a shorter course urethra. All right. Now, males have longer course urethra, which makes it more prone to trauma and injury. Females have shorter urethra, which will make it easier for a bacteria to climb up into the renal tract, causing an infection. Pyelonephritis may present with pain, usually in the sides and the flanks, fever and chills, nausea, and then increase in urinary frequency. The acute type is usually the type of infection that we see following an ascending bacterial infection, and as an acute infection it will cause acute inflammation. So you can see the infiltration of polymorph nuclear cells in the tubules, primarily neutrophils. Sometimes the acute infection may transition and become a chronic type of infection, and this is usually when we see plasma cells. Now, if you remember, plasma cells, they're indicative of chronic type of infection, and this, if it's chronic, it means it's for a longer period of time. It could predispose and progress into kidney failure. One of the problems that we see with bacterial infections is the renal abscess, and that could accumulate anywhere within the kidney, maybe basically within the upper pole, within the body of the kidney, and we always see there is necrosis associated with it. Because remember, pus is usually kind of the product of white blood cells fighting the bacteria. All right, so we see the liquid, we see the dead cells, and that could trigger necrosis in certain areas. The next topic on our agenda is ATN, which is short for acute tubular necrosis. As the name suggests, this is necrosis within the cells of the tubules, the renal tubules. Now, the epithelium may undergo necrosis in this particular scenario. Now, why would it happen? Well, it could be within the kidney, intrarenal. It could be something that relates to the output from the kidney. So for example, if there is obstruction in the ureter because of a stone, there is a tumor growing in the urinary bladder, or prerenal before we get into the kidney. So we usually see a change in osmolarity of the urine. There is elevated urine sodium, and there we see casts. Casts, they basically, imagine when we have a kidney tubule, if let's say a lot of epithelial cells within that tubule die and shed into the cavity, then they will take the shape of that tubule, and then eventually they are pushed into the urinary bladder and into the urine. So if we see casts within the urine, then that tells us about something within the tubule. So for example, if we see bacterial casts, we know there is infection. If we see dead epithelium cast, we know there was necrosis. If we see blood cell cast, we know that there was hemorrhage in the tubules, and so on. Protein may increase in the urine, and normally there is only a slight amount of protein in the urine because protein molecules are large. So if there is damage to the kidney, then proteins will leak out and we start to see them in large amounts in the urine. Although we'll save this discussion until we get into the glomerulonephritis. So what we're seeing here is a pale cortex, and we're seeing congestion within the pyramid. Pyramid is part of the medulla of that kidney, and it's the metabolically active component. Other problems will be diseases that affect glomerular function. So that means the efficiency, the capability of that kidney to filtrate things will change. It tends to go down. And this will allow everything to leak into the urine. So we may see blood cells, we may see fat, we may see proteins, and so on. The first kind of category is glomerulonephritis. So glomerulo, the glomerulus of the kidney, nephro is in reference to the nephron, and itis is inflammation. So this is inflammation of the glomeruli. Why would it happen? Well, classically, it is triggered by either an autoimmune mechanism for the most part, or post-infections. Now, if you remember when we talked about the cardiovascular system, we said unresolved sore throat, basically strep throat, could result in complications within the heart because of that streptococcus bacteria. Now, this is kind of another example of what could happen if there is an unresolved strep infection, which is really the glomerulonephritis. Now, the risk would be the streptococcal pharyngitis, genetics, particularly when it comes to autoimmune types. And what happens, because of the involvement of the glomerulus, the glomerular filtration rate will decrease, and the basement membrane may get damaged and it becomes leaky. So that's why we see proteins and lipids passing into the urine. So here you can see some of the immune-related mechanisms. In the first example, the first picture, you're seeing antibodies that are directly damaging the basement membrane. So they attack the proteins in the basement membrane, and now the basement membrane may become leaky. Or sometimes we see immune complexes. If you remember the term immune complex, it means it's an antigen antibody forming a mass. All right. Sometimes these immune complexes may deposit in the glomerulus, causing damage and or blocking of the filtration slits. So that will kind of restrict or interfere with how molecules move across the filtration membrane. Now, glomerular diseases can be divided into two types. There is the nephritic type and the nephrotic type. Nephritic type would involve basically proliferation of all cells thanks to the inflammation, the ongoing inflammation, whereas nephrotic, there is increased permeability of the glomerulus. From a clinical standpoint, if you hear about these in the hospital, you may see that doctors or nurses, basically when they talk about nephritic, there is kind of a clinical definition where the protein secretion is less than 3.5 grams per day, whereas nephrotic syndrome is when protein passing into the urine is more than 3.5 grams per day. But that's more of a clinical designation. So with the nephritic type, it's an inflammatory process. Because of that inflammation, we may see some hemorrhage, so we see hematuria because some red blood cells may escape into the urine. Now, the blood cells may clog the renal tubules, and that will result in a red blood cell cast. The GFR will decrease, and that means the nitrogen base will increase in the blood. Now remember, the kidney is the main organ in the body that helps the body eliminate nitrogen. If the kidney is not working, then the level of nitrogen will start to pile up in the blood. That's what we call azotemia. Now if you remember, nitrogen, the main source of nitrogen in the body is the amino acids, because part of their chemistry involves the presence of a nitrogen group. Now, the RAS system, the renin-angiotensin-aldo, may be activated, and we may see hypertension as a result. So patients usually present with hematuria, red blood cell casts, oliguria, decrease in urine output, proteinuria, but it's not as severe as the nephrotic. So because of the loss of that protein, we may end up with low protein level in the blood, hypoalbuminemia. Now technically, hypoalbuminemia is a type of hypoproteinemia. Because albumin is the most abundant type of protein, we're using its name in describing the condition: edema and hypertension. Now with nephrotic syndrome, there is usually damage to the glomerulus. That's when the membrane becomes really, really leaky. And when it's leaky, then a lot of protein will be passing through that leaky membrane and ends up in the urine. That's why the hypoproteinemia is fairly severe. It's basically way more severe than what we see with nephritic syndrome. So that means the oncotic pressure, the protein pressure, will decline because we have less proteins. This will result in edema, and that means the liver will try to manufacture another source of macronutrients, so it will produce lipids, and that will result in hyperlipidemia. Clinically, there is severe proteinuria, which will result in severe hypoproteinemia, particularly with albumin, so hypoalbuminemia. There is generalized edema. There is hyperlipidemia, and because of the extra lipid floating around in the blood, some of it may end up in the urine, causing lipid cast. Other problems may include cystic diseases of the kidney. Now, a cyst is basically a small kind of cavity that may contain fluid that develops within tissues. So here, the area I highlighted, this is basically a cyst, a solitary cyst growing in the kidney. Now, sometimes these cysts may be large, like the one you're seeing here. Now, some of them may be fairly benign, some of them may be mistaken by a tumor. But one of the most prominent cystic diseases that we see is a genetic variety, which is called adult polycystic kidney disease. Now, this is one of the most common genetic diseases. As the name suggests, polycystic kidney disease. It means the entire kidney is going to be replaced by cysts. The ones I'm highlighting here, each one of them is an independent cyst, and we're seeing multiple. Now, this is inherited through an autosomal dominant pattern and usually presents later on in life with symptoms such as hematuria, hypertension, and so on. So there is excessive cystic changes within the kidney. They usually develop over time. They're not present at birth. We may see inflammation and scarring, which will reduce the glomerular filtration rate and may present with pain, uremia, hypertension is probably one of the key ones, urinary tract infections, and hematuria. Eventually, it may lead to renal failure, and really the only curative treatment for it will be kidney transplantation, especially when the kidney reaches kind of full state of failure. And speaking of renal failure, now, as the name suggests, kidney failure is when the kidneys are no longer capable of doing what they're supposed to do. So that means the waste is not going to be removed, it remains in the blood, and nitrogen-based compounds will start to rise in the blood. And that basically applies to blood urea nitrogen and blood creatinine. Now, kidney failure, similar to a lot of other diseases, can be acute when there is like a sudden decline in the number of functional units, functional nephrons. Think of a direct injury, trauma, toxicity, or chronic, which is kind of a long-term ongoing process. The acute type could be pre-renal, post-renal, or intrarenal. Pre-renal, it means before we get to the kidney. Why would the kidney fail? Well, if someone is hemorrhaging in state of shock, then less blood will go to the kidney. Now, the kidney is a highly metabolic tissue. If you deny it of blood supply, even for a short period of time, that will result in cell death. So, if we decrease blood supply to the kidney because of a state of hemorrhage, then this will result in kidney failure. Post-renal, if let's say the urine output is blocked because of a stone in the ureter, a tumor, or an enlarged prostate in men, or within the kidney, basically if we see again ischemia, if we see toxins, whether toxins produced by bacteria, by infection, or toxins through things that we ingest, chemicals that we ingest. So pre-renal causes would include shock, hemorrhage, dehydration, those kind of go together, and then trauma or sepsis, severe infection. Intrarenal could be nephrotoxins. One notable example is the antifreeze. And post-renal, it's usually triggered by an obstruction of some sort, either an enlarged prostate in men, or a stone, or even a tumor. Tumor anywhere in the pressing on the ureter, pressing on the urethra, within the bladder, because if any of those are blocked, urine will backtrack into the kidney, causing the kidney failure. Kidney failure, once blood supply or flow goes down, there is oliguria, there is acute tubular necrosis, and then we go through the oliguric phase, then the diuretic phase, and then the kidney would recover. This is usually the consequence of acute failure, is that the kidney can recover, but it will need some time to recover. The chronic is the one we worry about, because now the remaining nephrons, the ones that have not died, they may have to either undergo hypertrophy to meet the demands, and they work extra hard. They take on like an extra shift to clear the blood, which kind of puts them under a lot of stress. So who's at risk of chronic renal failure? People who have glomerulonephritis, because it's mostly a chronic problem. People with diabetes, again, it's a chronic problem. Recurrent kidney infections and scarring, polycystic kidney disease, toxic or chemical, nephrotoxic chemical exposure, and obstruction within the urinary tract. I'm going to show you a slide of the stages of chronic renal failure, but let's agree that this is more of an FYI. This is more of a clinical discussion. But really, most of the take-home message is that only when the damage, the loss to the functional units, the nephrons, is really high, so that means over 90% of these nephrons are affected, are damaged, that's when we enter into end-stage kidney failure. So initially, if let's say 50% of the kidney is gone, we can still make it work. 70%, we can still make it work. All right, it's only when kind of we start to go close to 80% and higher, that's when we start to see the symptoms of kidney failure. So the way it goes with chronic renal failure, there is diminishing in the reserve, the renal insufficiency, renal failure, and the last one is end-stage renal disease. That's when, like I said, the only remaining treatment is either frequent dialysis or kidney transplantation. So here you can see atrophy within the kidney, and the cortex is becoming really thin, and that means serum or blood creatinine, urea, nitrogen levels will start to rise. Blood nitrogen level would rise. And here, patients may also be hypertensive. With end-stage renal disease, that's basically when the kidneys are shrunk. Like, look at the size of these kidneys, fairly small. And that's when we see the most severe symptoms of kidney failure. Now, once urea starts to build up in the blood, we call this condition uremia. And this is basically linked to a state of kidney failure when the kidney fails to remove waste. So that waste will accumulate in the blood. And other problems with kidney failure would affect red cell synthesis, because that's where the hormone that stimulates the bone marrow is produced, erythropoietin, and decrease in vitamin D activation, which will result in low calcium. Clinically, patients with uremia present with hypertension because the kidney is failing, edema because it's leaking protein, oliguria, and because of the accumulation of the toxic products, the brain may be involved. This is kind of like when we talked about, or we'll talk about it next week, cirrhosis within the liver and how toxins will build up. Anemia, because there is decrease in erythropoietin, and bone problems, simply because there is no activation of vitamin D, low calcium level, and bones will start to suffer. Now, hypertension may also affect the kidney. It begins through what we call a benign nephrosclerosis. Sclerosis means hardening within the kidney, within the vasculature of the kidney. The kidneys may start to become atrophic, they become smaller, and the afferent arterioles going into the kidney, they again become hardened a little bit because of that extra tension, and then we see scarring starting to form within the kidney. The classical appearance of that excessive blood pressure increase is basically the appearance of what's called the onion skin hyperplasia. Now, what you see here is kind of hyperplasia within the muscle, smooth muscle layer of the blood vessel, kind of giving it the same appearance of onion skin. Like if you cut a section within an onion, you see concentric layers of the onion peel. This is kind of where the analogy comes from, is that because of the ongoing high blood pressure and the subsequent sclerosis, the hardening, the smooth muscles within the blood vessel will start to kind of undergo hypertrophy, hyperplasia, so we see an increase in the thickness of the layer. This is usually the case when we have malignant hypertension. Malignant hypertension is basically hypertension that is really high, over 160, over 110. Now, because of the high resistance and the thickening, that means less blood will flow to the kidney, and we know that when there is less blood going to the kidney, this will activate the renin, angiotensin, aldosterone system. Because of the decrease in the activation of vitamin D, that means calcium will decrease, and if you remember, the gland to respond will be the parathyroid gland, increasing the level of parathyroid hormone. Parathyroid hormone will start to extract the calcium from the bone, so blood calcium would increase, and that means the bones will become weaker over time because we're taking the calcium outside of them. The next kind of topic we have on our list has to do with obstruction to the renal or the urinary system. Now, why would that occur? Well, there are several causes for kidney obstruction. There are several locations for where that obstruction may occur. It could be triggered by tumors anywhere in the urinary tract, in the pelvis. It could be triggered by a stone, by an infection, by prostate enlargement. So here you can see some examples. Infection. We could see hyperplasia within the kidney, within the prostate gland. Imagine a tumor growing somewhere here, blocking that ureter. Urine is backtracking. When we have obstruction, the urine will accumulate in the ureters, dilating them, and eventually it will go back and stay within the kidney, dilating the kidney, causing hydronephrosis. Here you can see the dilated ureter and the dilated kidney. Now this is usually the case when we have chronic type of obstruction, and let's say a stone here, that stone will block urine output, so the ureters will dilate, the kidney will dilate. That's why we usually see it unilaterally. Now here, if we open up that dilated kidney, we can see that the thickness of the cortex is reduced. It's becoming really, really very thin because of the compression. Speaking of stones, stones could occur within the kidney, that we call them colliculi or colliculus. Nephrolithiasis is the other name, urolithiasis. They usually occur in young adults, and they could be triggered by several things. Calcium stones remain the most common, infectious stones with certain bacteria, and uric acid stones in patients with elevated levels of uric acid. As I said earlier, the majority of those are calcium stones. They affect about 75% of all stone patients. They are hard, they are dark, we can see them in an X-ray for the most part, and they block anywhere in the kidney. Now, when urine doesn't move, that means bacteria may find it an attractive medium to grow, and when bacteria grow, they can produce their own stones, which are magnesium stones as opposed to calcium stones. As far as uric acid, it's not a very common type, but it's usually seen with patients who have metabolic disorders, particularly gout. In gout, there is usually hyperuricemia, so elevated uric acid in the blood, which could deposit in the kidney as a stone. So here you can see all what you see in here is actually the stone. This is a staghorn stone. This is usually triggered by infection, and it takes the shape of the area it's occupying, whether it's the ureter, the calyx, or the pelvis of that kidney. All right, the last kind of topic on our renal system agenda would be dedicated to tumors. Tumors similar to everything we've seen before. They could be primary tumors originating anywhere in the kidney, uroepithelium, or they could be metastatic tumors. They start somewhere else and find their way into the kidney. So we're going to look at three main types, common types: renal cell carcinoma, transitional cell carcinoma, and Wilms tumor. The first one, renal cell carcinoma, is a fairly common tumor. There isn't a specific risk factor that has been linked to it. Tumors usually occur later on in life, and they have poor prognosis. Renal cell carcinomas, they are slow growing, but they could be, or they could reach a large size before we detect them, simply because they grow in the abdomen. Now, usually these tumors are unilateral, so if one kidney is compromised, remember there is the other kidney that is still working. We may see mass effect because of their growth. We may see bleeding, so we may see hematuria, and we may see pain in the flanks. And here you can see that it's still at an early stage, just starting to grow. The kidney is still not fully involved. The other type is urothelial carcinoma. This is very common, and it affects the transitional epithelium within the urinary tract. These tumors, they usually present with hematuria, and examinations, particularly pathological histological examination, will show all the malignant cells shedding from the surface of that tumor. Here we're looking at an example of a bladder cancer. All right, this is basically the tumor. Now remember, the bladder should not have anything inside of it. It's just a cavity for storage of urine. But now we're seeing growth of abnormal tissue. Now, the cortex, the medulla, they usually, in this particular case, you can see that they are normal. But if the tumor is aggressive and rapidly growing, it may invade into the parenchyma. It could obstruct the output of each kidney, and they present with, or patients will present with, a state of hematuria. The last of these tumors is called Wilms tumor. It's a tumor that occurs during childhood and infancy. It's one of those immature tumors, the cells that do not show full maturity. Prognosis is fairly good if they are detected earlier and removed surgically, and treatment is supplemented with chemotherapy. Now, what you see here is a small kidney that has a mass, a tan white mass. Now, usually Wilms tumor, there is a specific mutation that can be passed on chromosome number 11, and these tumors grow very large. So in a child, a rapidly growing mass in the abdomen, basically where the kidney is usually the tell sign. And that will cause a mass effect, and it will warrant further investigation and then subsequent surgical removal, and so on. All right, so this concludes the renal section. Thank you.